Hey all, welcome back to the Real Life Pharmacology Podcast. I am your host, pharmacist Eric Christensen, and I thank you so much for listening today. Go check out reallifepharmacology.com. We got your free 31-page PDF on the top 200 drugs. No-brainer to have. Simply an email will get you access to that. We'll also get you update when we've got new podcast episodes and other content available too. So go do that at reallifepharmacology.com. We are continuing on with the top 200 drugs today, and we are on number 96. This medication is methadone. Brand name is methadose. And classification, it is an opioid analgesic. I will say in practice, I typically don't see this medication used terribly often for pain management. I would say in patients I see it more often used in opioid use disorder. This medication helps reduce withdrawal symptoms and cravings, obviously associated with opioid use disorder there. So how does it work mechanistically? It binds to opioid receptors in the central nervous system. It is a full opioid agonist that is slightly different from, let's say, buprenorphine in opioid use disorder, which is a partial opioid agonist. So there is a little bit of difference there. As far as boxed warnings, there are a bunch on this medication. Obviously, being a full opioid agonist, we've got the risk for addiction, abuse, and misuse potential. There's also various dosage forms, particularly in relation to concentrations and liquids. So we've got to be extremely careful with that. If you give patients, dispense the wrong concentration, and you tell them to take a set amount of volume, that could definitely lead to a situation where we give an inappropriately high or excessive dose, obviously unintentionally or in error. So really got to be careful when we're talking about different concentrations of methadone. Double, triple checking, having processes and procedures in place as far as, dispensing and prescribing, making sure that we're not willy-nilly with those different concentrations, because that can definitely lead to a life-threatening situation if we get the wrong dose there. Risk of respiratory depression is another boxed warning, particularly with the use or combined with benzodiazepines. And there's a bunch of drug interactions with methadone as well. So I think some of those reasons, maybe the drug interaction thing particularly, is why methadone has fallen out of favor a little bit compared to the use of other opioids in association with pain management. Memorable side effects, what are you going to see on your exams and in practice? Well, of course, if the dose is too high or excessive, we can put patients into opioid overdose. So you can potentially see respiratory depression, obviously, coma, and ultimately death as well if that dose gets too high or if patients inappropriately take excessively high dosages. Other opioid adverse effects, constipation can certainly happen. You can get some skin reactions, some pruritus, itching, those type of things as well. But specifically with methadone, I did want to mention QT prolongation. The risk seems to be a little bit higher with methadone compared to most of the other opioids. So that is another challenge, and I think of it particularly in my geriatric patient population who already may be at risk due to other medications or conditions that may put them at risk for QT prolongation. Adding methadone on top of that could increase or worsen that risk. Methadone has a relatively quick onset of action within 10 to 20 minutes for analgesic purposes. And with that, it can be utilized for pain management. But again, I've talked about some of the risks there. And I'll go into details at the end here with regard to drug interactions and some specifics there. But that's really a big challenge associated with using it for pain. And why I've historically seen less and less use of this medication as we've learned more and more about drug interactions and pharmacokinetics with it. The other major challenge when we're switching opioids is conversion with methadone. Conversion, I'm not going to go into it, step by step on this podcast episode, but it's very, very tricky and difficult, and it's based upon how much opioid you're already taking. That conversion can vary significantly, and it's based on percentages as well as the initial dose of opioid you're on. So that percentage transition can change, based upon how much opioid you're taking. So again, very, very tricky. Definitely something that doesn't happen very often. I've worked with it a couple of times with providers and patients throughout my career. But again, one of those things where it's like, you really want to look that up, make sure you know what you're doing if you don't do that on a regular basis when we're talking about converting from methadone to another opioid or vice versa. Lastly, let's finish up on drug interactions. So QT prolongation, that is definitely something, a risk as far as drug interactions go. So I think of antipsychotics, I think of citalopram, I think of amiodarone and other antiarrhythmics. These are all meds that can exacerbate QT prolongation, and certainly with methadone on top of that is going to increase that risk. Other drug interaction I alluded to as well, benzodiazepines at increased risk for respiratory depression. That is a boxed warning. And then there's also a warning on cytochrome P450 enzymes, 3A4, 2C19, 2C9, 2B6, 2D6. Methadone is broken down by multiple pathways, and blocking or inhibiting some of those pathways can increase concentration. So, and from a drug standpoint, there's lots of drugs that inhibit those different pathways. But there's even things that aren't considered medications, like grapefruit juice, for example, that inhibits CYP3A4. That can increase methadone concentration. So again, another kind of strike against its common use because we've got so many things that could raise its concentration. So, and with grapefruit juice, if you're interested more in that and drugs that it inhibits and drug interactions with grapefruit juice specifically, I'd refer you back to a podcast I previously did specifically on grapefruit juice drug interactions. So go check that out for sure. Again, methadone generally avoided. I would say hospice is probably the rare situation where I see it used other than potentially opioid use disorder periodically. All right, next medication, number 97, is Enalapril. Brand name of this medication is Vasotec. It is an ACE inhibitor. I've covered a lot of ACE inhibitors previously. Mechanistically, it prevents the conversion of angiotensin 1 to angiotensin 2. Remember that angiotensin 2 is a potent vasoconstrictor. So by blocking the formation of angiotensin 2, we essentially allow for vasodilation or relaxation of those blood vessels, which can help drop blood pressure. So naturally, Enalapril can be used for the management of hypertension. Some of the testable side effects, if anyone ever presents with a cough, dry cough specifically, you got to rule out an ACE inhibitor like Enalapril. Orthostatic hypotension, I think that kind of comes with the territory. If you drop blood pressure, certainly you can drop it too far. In some patients, cause dizziness and fall risk and orthostatic hypotension. Hyperkalemia, elevations in potassium, and issues with acute kidney injury. Not terribly common that acute kidney injury happens, but that's why we follow creatinine. And then obviously the hyperkalemia is why we monitor potassium levels as well. In the management of blood pressure, typically we're going to start a medication like Enalapril. In my geriatric patient population, typically we start low, go slow, and then we generally reassess those patients within 2 to 4 weeks with follow-up lab work, again, looking at that potassium, looking at that creatinine, and then obviously checking that blood pressure out as well, and seeing if we're benefiting it, making sure the patient's taking the medication, and so on and so forth. From a drug interaction standpoint, I don't worry tremendously about Enalapril. With that said, we've got some additive effects that could happen. So in relation to potassium, so taking it with spironolactone, an ARB is not appropriate with an ACE inhibitor, such as losartan, for example. So these can all increase the risk of hyperkalemia, and definitely something you want to pay attention to there. Blood pressure, obviously, is going to drop, so using other antihypertensives or other medications that you may not think of as antihypertensive but have blood pressure lowering effects, we can certainly have some additive effects there. We can also increase the risk for renal toxicity if we're taking, let's say, NSAIDs or maybe diuretics, for example. This can increase the risk of acute renal failure as well, and a rising creatinine. All right, moving on. Next medication, we've got number 98. That's Oseltamivir. Brand name is Tamiflu. Classification, it's an antiviral medication used for treatment or potentially prevention of influenza. So mechanistically, it is a prodrug that's hydrolyzed to the active form, and that active form inhibits influenza virus neuraminidase. So classification-wise, it's also called a neuraminidase inhibitor. And that neuraminidase is important for viral replication. Adverse effect profile, I would say there's two major things you need to know for exams, board exams, pharmacology exams. GI upset certainly can happen with this medication, nausea, vomiting. Psychiatric changes have also been reported. So if you see a new start of this medication, definitely want to pay attention to any changes in psychiatric issues as well. That has been reported. Again, not incredibly common, but definitely something that I've seen periodically. There are dosage adjustments for reduced renal function, so that's something to pay attention to, particularly in our elderly patients or those with a known history of CKD. We want to make sure we get that dosed right so we don't overdose them. Prophylaxis and treatment dose, as you can imagine, there is different dosages for that. So prophylactic dose, again, assuming normal renal function, is 75 milligrams once a day, whereas the treatment dose is 75 milligrams twice a day. But again, look at that renal function, make sure we don't have to dose adjust or reduce that dose with poor renal function. Drug interactions, there aren't a tremendous amount of drug interactions that I'm concerned about here. There are some vaccines that may not be as effective, and obviously influenza being one of them. Generally do not give this medication with a vaccine or with the influenza vaccine. So hopefully that's common sense, but it might not be if you're just learning medications and those type of things. Rarely, you may see it cause some elevations in INR. I would say it's probably not as strong of an interaction as some other ones and maybe some of the antibiotics that I think about. But that has been associated with raising INRs as well in patients taking warfarin. Moving on, we've got 99, which is Ropinirole. Brand name is Requip. This is classified as an anti-Parkinson's agent. I will say it's not used incredibly often for Parkinson's. I would say it's used more often for the management of restless leg syndrome. Mechanistically, it is a dopamine agonist that has a higher affinity for the D3 receptor compared to other dopamine receptors like D2 or D4. Recall that interplay with dopamine. So antipsychotics block dopamine, and dopamine agonists or dopamine replacement, such as with Sinemet, those basically stimulate dopamine. And in Parkinson's disease, we have a shortage of dopamine. Okay, so giving a dopamine agonist or giving dopamine in the form of Sinemet, or increasing dopamine in the form of Sinemet, those can help treat Parkinson's disorder. But again, Ropinirole, typically I see it used much more often for restless leg syndrome. And probably the easiest way to tell, most patients who struggle with RLS will have symptoms at night. Occasionally you can have some patients that do have symptoms during the day. But if you see Ropinirole dosed just at night, it's likely that indication is restless leg syndrome. If it's dosed multiple times per day, then it could be for either, but it might be being used for Parkinson's syndrome. All right, adverse effects, GI can happen, nausea, vomiting. Orthostatic hypotension is definitely one to look out for with this medication. Okay, and that is dose-dependent effect, so higher the dose, more likely you maybe run into that. Can see some sedation sometimes. Rarely have seen some edema reported as well. So monitoring parameters, blood pressure. Probably a good idea to keep tabs on that, and I would say especially if you've got a patient that's reporting some dizziness for sure. All right, drug interactions with this medication. So think about that interplay with dopamine, and it makes sense that using an antipsychotic that blocks dopamine could potentially lead to blocking of Ropinirole's effects as well. So again, use of antipsychotics may lead to reduced effectiveness of Ropinirole. Other drug interactions, think of the additive hypotensive effect. So, PDE5 inhibitors like sildenafil, for example, for erectile dysfunction, that can have a hypotensive type effect. So adding that on top of Ropinirole, that may increase that risk. Alpha blockers like tamsulosin for BPH, another good example there of a non-blood pressure lowering medication that could have some hypotensive effects. So keep an eye on that. Again, that's that blood pressure piece of it. And then we've got CYP1A2 inhibitors. Those are going to be important to pay attention to. Ropinirole is broken down by CYP1A2 to a certain extent anyway. And it could increase concentrations of Ropinirole if we use a CYP1A2 inhibitor. Some drugs that inhibit CYP1A2, not incredibly common, but ciprofloxacin, cimetidine, fluvoxamine, these are some agents that can inhibit CYP1A2 and increase concentrations of Ropinirole. Reminder, I do have a free drug interaction PDF at meded101.com. So if you subscribe there on the blog at meded101.com, you can get that free PDF on drug interactions. And there's a lot of interactions in there, a lot of CYP enzymes. I lay out which drugs interact with which. So definitely a good little resource to have, and a free PDF at meded101.com. All right, so now we've got number 100, and that is penicillin. This is a beta-lactam antibiotic, one of the original antibiotics ever created or invented, and it targets mostly gram-positive organisms, so strep throat, that's group A strep, for example. Skin and soft tissue infections are often gram-positive, so you may see it utilized there. It can also be used as an option in treating syphilis as well. Mechanistically, it inhibits cell wall synthesis by binding to penicillin-binding proteins, and that ultimately stops growth and kills the bacteria. Adverse effect profile is pretty much primarily GI, nausea, vomiting, and particularly diarrhea. With that said, we can have some skin reactions as well. Many patients have a penicillin allergy. Not something I'm going to go into great detail on today, but making sure that your patients actually have a true penicillin allergy can be definitely an important thing to do at some point in their lives to make sure that we truly can't or shouldn't use penicillin antibiotics, because there is a lot of controversy on how many patients actually do have penicillin allergies. So again, definitely something that could be looked at periodically there. From a drug interactions standpoint, not a ton that I am too concerned about. May have some modest increase in INR, patients using warfarin there. Also, if it's being used in combination with other antibiotics, it may reduce the efficacy. Tetracycline antibiotics, aminoglycoside antibiotics, again, not something that happens incredibly often in practice, but just something to be aware of there. And then there may be some reduced effectiveness of certain types of vaccines. Cholera and typhoid are specifically listed within the information regarding penicillin there. If you enjoyed these practice pearls today, please go support the sponsor, meded101.com/store. We've got tons of resources there, from Amazon books, review courses, BCPS, ambulatory care, NAPLEX, BCMTMS, geriatric exam. Lots of different resources there at meded101.com/store. Your support there goes directly to support this podcast. So greatly appreciate that if you'd go check that out and support the sponsor and help keep this podcast free and available for all to benefit from. If you want to check out that free PDF, you can do that at reallifepharmacology.com of the top 200 drugs. Simply an email will get you access to that. Comments, suggestions, don't hesitate to reach out to me at mededucation101@gmail.com. I definitely do my best to respond to all the emails I get. So if you don't get through the first time, please don't hesitate to try again. If you enjoyed the podcast today, share us with friends, colleagues. Leave us a rating, review on iTunes or wherever you're listening. I greatly appreciate that as well. And again, don't hesitate to reach out if you've got any comments or questions at mededucation101@gmail.com. Thanks so much for listening. Take care, and I hope you have a great rest of your day.